Yeah. Good afternoon, dear friends. On behalf of ESAR Team 2021 and DocMode, I welcome you all to this weekly webinar of ours. Today, I have with us Miss Alexia. Can I have her slide, please? Miss Alexia Chatziparasidou from Thessaloniki, Greece, who's a consultant clinical embryologist with an experience of more than 45,000 cycle in ART. And she is well known for her special interest in efficient total quality management, for which she was awarded a certification in 2020. Congratulations, Alexia. And to look at her dedication, let's see that in 2004, Mrs. Alexia co founded Embryo Lab, a well known and modern state of the art fertility clinic located in Thessaloniki, Greece. And for this, in the same year, she was awarded with her master degree on clinical embryology from Leeds University. And in 2008, she was certified by ASHRAE as senior clinical embryologist. In 2013, co-founding Embryo Lab Academy and co-organized a series of international workshops on quality management and RM for ART units, cryopreservation, and pre-implantation genetic diagnosis. So, friends, let's welcome Dr. Miss Alexia Chatziparasidou from Thessaloniki, Greece, a very good friend of mine and a lively person. And we are waiting. She's going to talk about non-obstructive azoospermia from diagnosis to management. Welcome, Alexia.
It's an honor for me to be here with you. I really would wish and I pray for the moment I will be able to be with you in India.
Same here.
Hopefully, the situation will resolve soon so we can visit each other and hug each other.
Yes.
So, thank you for the invitation. I'm going to share my screen now, so I will be showing my. Can you see? Can you see my slides? Can you see my slides?
Yes, ma'am, your screen is visible. Yeah. Please put it to slideshow.
Sorry, I'm sorry. So my lecture today is on non-obstructive azoospermia from diagnosis to treatment. And let me tell you that it's one of my favorite topics. It stands next to quality control and risk management, which is my next favorite topic. So I have no conflict of interest. And we do know from the data we have in our hands that approximately 15% of the couples trying to conceive experience delays in conceiving, which equals around more than 70 million of couples suffering from infertility. In 20% of the cases, an exclusive male factor is involved, while in 30 to 40%, male factor is contributory, which means that it coexists with a degree of female factor. Azoospermia is one of the most severe form of male infertility, and it is identified. It is the situation, the condition where there is which is characterized by total absence of spermatozoa in the ejaculate after centrifugation in at least 2 samples. And we know today that approximately 15% of the infertile males are azoospermic, which equals to 1% of male population. Azoospermia, based on the ability of the testicles and the testes to produce and deliver spermatozoa, is classified into 2 types. It's the non-obstructive azoospermia and the obstructive azoospermia. The best form of azoospermia in terms of chances and prognosis obviously is obstructive azoospermia. In obstructive azoospermia, testicles have a good structure and spermatogenesis is normal. And the reason of azoospermia is the presence of an obstacle somewhere along the male reproductive tract, such as in vas deferens, in epididymis, or the ejaculatory tract. Unfortunately, the most common type of azoospermia is the other type, the non-obstructive azoospermia, where we have a severe impaired spermatogenesis or absence of spermatogenesis, no spermatogenesis. In these cases, the spermatogenesis is impaired, and it represents the higher percentage of the azoospermic men. Historically, azoospermia was considered untreatable. A diagnosis of azoospermia was synonymous to sterility, and all this up to 1992. Thanks to the progress of our means and the implementation, the breakthrough development of intracytoplasmic injection, since 1992, we were able to test the efficiency and the reproductive potential of testicular spermatozoa. And it was soon becoming apparent that despite the previous ideas and theories that these spermatozoa are not able to fertilize and support embryonic development or to lead to a viable pregnancy, testing their ability proved that spermatozoa from the testicles, which are quite often present in azoospermic men, are able to fertilize, to support embryonic development, and to lead to viable pregnancy. So after 1992, it was only after 1 year that this was confirmed. In 95 to 96, we had the report of the first pregnancies. And since then, a pathway, a roadmap for the azoospermic males was developed, which approximately has remained the same over the years. So once it is verified in at least 2 samples that this man is azoospermic, then the next step is the session with the andrologist or endocrinologist, where a detailed medical history is taken together with a clinical assessment. And based on the data from this step, an investigation will be recommended, which normally includes hormonal testing, ultrasound scan to check for the vascularity, or a series of genetic tests. And the purpose of this investigation is to distinguish azoospermia acquired and non-acquired or congenital azoospermia, to identify which conditions of azoospermia may be reversible, the overall prognosis, and in general, we try to improve patients' management and care, and address a number of questions that normally the azoospermic men have. It's normal, and we get it very often. We get very often questions like, what is the cause of my azoospermia? Let us see. At the moment, today, after all these years working with men suffering from azoospermia, we have classified azoospermia, the causes of azoospermia, depending on where in the anatomy of the man the cause is lying, in 3 types: the pretesticular causes, the testicular causes, and post-testicular causes. But quite often, we have no cause in our hands. And in these cases, azoospermia is classified as idiopathic. Another question that very often arises, obviously, is my azoospermia reversible? Most often, azoospermia is congenital rather than acquired. in only a small fraction of men with azoospermia, which represents almost the 3% of the azoospermic men, where the reason, the cause lies in the central system, and it's known as hypogonadotrophic hypogonadism. It's the only type of azoospermia that is considered reversible, where a medication that aims to stimulate the testicles will eventually restore fertility in at least 80 to 90% of these males. And these males are the only azoospermic men that can hope for the restoration of their fertility and to a spontaneous conception even. For all the rest types of azoospermia, the obstructive azoospermia, whether it's acquired or non-acquired or congenital, or the non-obstructive azoospermic men, which represents more than 70% of the azoospermic males, the most common way or the only treatment option is for them to undergo a kind of biopsy in order to explore the presence or verify the presence or absence of spermatozoa. And once the spermatozoa, we have a positive biopsy outcome, we can proceed either to fertilization via intracytoplasmic ICSI or cryopreservation for later use. Or in case of a negative biopsy outcome, then alternative options are available for the couple, such as sperm donation or adoption. Another question: what are my chances for a positive testicular biopsy? While for obstructive azoospermia men, the chances for sperm retrieval and positive outcome are very high. For non-obstructive azoospermia, this is a huge challenge, as there have been for the moment, and after many studies and attempts to identify the sole biomarker or a combination of biomarkers that may provide us a strong prediction for the presence or absence of spermatozoa in the testes, we have reached a point where we acknowledge that for the moment there is no a biomarker that could safely lead us to avoid an unnecessary biopsy or to proceed to a biopsy with very high chances of finding spermatozoa. So whatever the biomarkers, we still have to proceed to the biopsy to verify the absence or presence of spermatozoa, which makes things a little bit difficult for the couples suffering from azoospermia, because they have to undergo to all these steps, feeling all these high levels of anxiety. The only markers that could safely help us avoid an unnecessary biopsy is only it relates to a very small fraction of patients, azoospermic patients, the ones that have been diagnosed with the male syndrome 46XX, with the absence of the grants of the YQ chromosome, or they have a complete deletion of the ASF-A or ASF-B and C. Only in these cases, the chances of a positive sperm retrieval are practically nil. And there have been lots of attempts and to identify the biomarkers that would safely predict the presence of absence of spermatozoa. And while we don't have anything, a parameter that would give us this answer, it's over the last year we have seen artificial intelligence and deep learning and machine learning entering this field. And there has been several reports. They report not strong at the moment prediction level, and I just have included this piece of work which really attempts with the use of deep learning and machine learning to optimize our prediction efficiency. So these while it's not mature at the moment, it paves the way and gives us another option and another way to hope for in the future. What are the chances to maximize what can I do to maximize my chances for a positive biopsy? This is another very frequent question. And since all these years where we have worked with testicular spermatozoa for non-obstructive azoospermic men, there have been lots and lots of reports reporting attempts where, with the use of medication or vitamins or interventions such as varicose cell repair, they had positive experience and positive results, which means that they had higher level of spermatogenesis and improved chances for finding spermatozoa. Together with or in combination with lifestyle adjustments such as diet, body mass index correction, or the cessation of smoking. While all this seems to be at the right direction, for the moment, they do not provide very strong evidence in order to encourage all of the non-obstructive azoospermic men to undergo these pre-operative optimization, since things and the evidence is not strong for the moment to ensure this man about who's going to benefit in one of these from one of these procedures. What are the recommended or the optimal dosages or duration of treatment in case of medication for each of the types of azoospermia, of non-azoospermic men? So this is the reason why the European Association of Urology, they do not advocate this kind of procedures for preoperative optimization, and they do consider that biopsy, testicular biopsy, or this surgical biopsy, whether it's MESA or TESA are the way to go for these men. For optimization of sperm retrieval and in order to increase the chances of positive outcome, over the years we have different surgical procedures that have been developed in order to maximize the chances for a positive outcome, such as MESA or TESA, which or PESA, which involves the intervention on epididymis, or TESA or micro-TESA, which involves the intervention to the testicles directly. Depending on the type of azoospermia and what we expect, choosing the correct intervention, it's very critical as well. Is micro-TESA a better option for me? Very, very frequent question. It has micro-TESA. It's a procedure which is based on the identification of these tubules that seems to have higher thickness, which means that the surgeon is, with the use of microscope, will be focusing after exposing the testicle on these tubules that seems to have higher thickness and hence higher chances for having active spermatogenesis in them. And while there are data that confirm the superiority of micro-TESA for this group of azoospermic patients, the non-obstructive azoospermic males, there are studies that report otherwise, where they saw no additional benefit when comparing micro-TESA, which is a highly complex method and very with higher cost and demanding in terms of technological support, in comparison when they compared the positive retrieval sperm rate when performing the conventional testicular biopsy, where one or more tissue samples are retrieved. So this has to be, we have not reached a consensus on that, at least for the moment. Are frozen testicular spermatozoa equal to fresh? This is a big question. Once this needs to be decided during the investigation and before we agree on the treatment plan. Men with non-obstructive azoospermia have the option to undergo first with a biopsy, and in case of a positive outcome, the spermatozoa, the testicular spermatozoa, can be frozen and can be used later on after the stimulation and egg collection of the wife. While another approach, so this is basically a step-by-step approach. First, you verify the presence of spermatozoa, and once it is positive, you proceed with the ovarian stimulation and egg retrieval. So by doing this, you have a lower need for repetitive biopsy procedure. It's more cost efficient in terms of you don't you take it step by step, but the shortcomings are that you may lose some spermatozoa due to the cryopreservation procedure, and you may have a degree of cryo damage to the spermatozoa that will be selected eventually for fertilization. Another attempt, another way for them, another option is to schedule the two procedures at the same day. On the day of egg retrieval, we schedule the TZ procedure or micro-TZ procedure in order, once the spermatozoa are found, for them to be used immediately as fresh for the oocytes. And the benefit of this approach is that we use fresh spermatozoa and there are no worries about cryo damage. But the shortcomings of this approach is that the complexity is higher, it's much more demanding for the couple and for the system that will take over the treatment. There is always a risk of cycle cancellation when the outcome is negative, unless the couple is willing to proceed with sperm donation the very same day or oocyte cryopreservation. And this is considered cost inefficient because it demands the stimulation of the wife, and which includes the risk of cancellation. According to a recent meta-analysis in 2018, it has been shown in over 1,200 cycles that when comparing cryopreserved testicular spermatozoa to fresh testicular spermatozoa on the basis of fertilization rate, cleavage rate, good embryo rate, implantation rate, clinical pregnancy rate, and live birth rates, they were all comparable. Which means that according to this meta-analysis, we shouldn't be worried or concerned when offering the stepwise approach to our couples and our patients. We should encourage them to take it step by step instead of taking the risk of an unnecessary stimulation. However, we still have a way to go because there are studies reporting otherwise. Like these studies where they have concluded that for them, at least for their setting, fresh testicular spermatozoa perform much better in terms of ICSI, or they have higher fertilization and clinical pregnancy rate with the fresh rather than the frozen spermatozoa. And this is where it becomes a challenge when you really want to help and support and offer and provide the best care for your patients. And maybe the reason behind these different points of view and different conclusions is because of the patient characteristics, or, which I think it's highly likely, the different cryopreservation protocols we are using because you can see that there is a big variation from setting to setting and lab to lab on how they cryopreserve the testicular tissue and how they process the testicular tissue before and after cryopreservation, and how we select spermatozoa post-thaw. Obviously, all these different approaches may reflect to different functionality of our spermatozoa after thaw. And another parameter that really attracted our interest is the overall quality of the testicular tissue. Let me comment on that. We, as Embryo Lab, are working quite intensively with non-obstructive azoospermia. I told you it's one of my favorite topics, which means that we have dedicated time and effort in optimizing these our approaches and procedures when treating non-obstructive azoospermia patients. So the question we had and wanted to be addressed was whether the quality of the testicular tissue may have an impact on the overall clinical and embryological outcomes. So we classified our testicular tissues according to the presence of spermatozoa, the presence or not of motility, and the total absence or not of good morphological spermatozoa. And we created two groups, the ones with all of them in good level, and the low quality tissue that contains spermatozoa, rare presence of spermatozoa, or low morphology or no motility. And what we've done was to compare the outcomes, the embryological and clinical outcomes of fresh and frozen in good quality tissue and fresh and frozen in low quality tissues. And what we've seen was that in the first group, the clinical and embryological outcomes, whether the spermatozoa used were fresh or frozen, were comparable. So for the good tissue quality, there is no difference when working with fresh or frozen testicular spermatozoa. While in the other group, the low quality testicular tissue, there was an encouraging fertilization rate comparable. But when it came to good quality embryos on day 3, there was a difference that favored the fresh spermatozoa, which means that for this subgroup of cases, the low testicular tissue cases, we had 1.57 more good quality embryos on day 3, while the other clinical outcomes were comparable. Another question, are these spermatozoa, in case of a positive outcome, able to support embryonic development? There are lots of studies that try to address this question. And while the characteristic of these studies is that they are based on the experience of one laboratory, and the number of the cases it's not that high, which reflects our need for collaborations in order to draw solid conclusions and to be able to provide our patients with solid and really evidence-based answers. I will go through what is available in the literature for us to know. For example, first and all, when we compare non-obstructive azoospermic males to obstructive azoospermic males, and I remind you that obstructive azoospermic males are the ones that have a very normal spermatogenesis, it is well known now that non-obstructive azoospermic spermatozoa perform lower compared to obstructive spermatozoa, which means that we expect them to have lower fertilization potential and lower pregnancy rate. And there is a big and very well-known study back in 2015 by the VUB University, where they confirmed the retrieval rate for non-obstructive azoospermic men up to 40.5 5%, lower fertilization rate when compared to ejaculate spermatozoa, and at the end, they concluded that in the unselected non-obstructive azoospermic patients, only a 13.4% of them will eventually father their own genetical child. In another study where they were focusing on the AZFC microdeleted patients, which is a fraction of the non-obstructive azoospermic males, they saw that while these patients had favorable results, the higher retrieval rates in comparison with the non-AZFC microdeleted patients, what they saw is that these spermatozoa tend to perform lower in terms of fertilization rate. Are the spermatozoa able to support blastocyst stage development? In a recent study by Dr. Lee and colleagues in 2018, they saw and they concluded that non-obstructive azoospermic, non-obstructive spermatozoa, testicular spermatozoa, are equally able to support fertilization and blastocyst rates. And implantation, clinical pregnancy rate, miscarriage, and delivery are also comparable. Cancer survivors. Some of the acquired forms of non-obstructive azoospermia is after chemotherapy. So in this study, they tried to compare the sperm retrieval rate and the clinical and embryological outcomes in non-obstructive males that have, in comparison to that are cancer survivors in comparison to the non-cancer survivors, the ones that never had a cancer. And they saw that they had comparable retrieval rate, the comparable cumulative pregnancy rate. The cancer type did not affect the outcome, which is good news for us to know. And obviously, what we know that female partner age plays a critical role, and they also confirmed that female partner age tend to be inversely related to the cumulative live birth rate. Back to our study. We also wanted to address some of our questions, and what we've done is to compare Group A performance in terms of embryological and clinical outcomes to Group B. I remind you that Group A are the good testicular quality tissue, and Group B are the ones with low morphology, low motility, low presence of spermatozoa. What we saw is that while the other variables were comparable, we've seen in Group B, the low quality spermatozoa, we've seen lower number of good quality on day 3. So we tended to get in this subgroup of population 1.5 less for the Group B or more for Group A, good embryos on day 3. Rare spermatozoa, it's always been a question for me, how long should I look for spermatozoa and search for spermatozoa before I quit? Does it worth my effort if I find one spermatozoa after 1 hour of searching? So we tried to address this question, and we found that despite the rare presence of spermatozoa in some samples, it's always worth looking for them, because once found, they can provide us with an acceptable fertilization rate, which is obviously lower than in samples where we have quick or average time of finding spermatozoa. But once they are found and they produce embryos, the clinical outcomes and the development of embryos seems to be to work well. So which is encouraging in terms of once you find spermatozoa, then you may have embryos and good clinical and implantation rates. So absolutely the answer is yes, it was the trouble and the time spent on our microscopes. Absence of motility. How does this affect our outcomes, the clinical and embryological outcomes? In our experience, it does not affect the fertilization rate, but it seems to affect the number of good quality on day 3 embryos. In our setting, we get to have, when we have very, very low or absence of motility, we tend to have 0.45 less good embryos. And what about poor morphology? Should we what are the chances when only low morphology spermatozoa are found in our samples, testicular samples? In our experience, we saw that even in low, poor morphology samples, we get to have an acceptable and comparable fertilization rate, but we tend to have lower good morphology on day 3, good quality on day 3 embryos, up to 0.75 embryo less, compared to the samples with presence of good present spermatozoa with good morphology. Morphokinetic behavior. Thanks to this new technology, we are able to follow the morphokinetic patterns of our embryos, and that means that this technology creates a huge opportunity for us to study variations or deviations of the morphokinetic pattern of the embryos produced from non-obstructive azoospermic males. And since we do know that spermatozoa plays a critical role on oocyte activation, on pronuclei formation and syngamy, in mitotic divisions, and in the compaction procedure. So it is a huge opportunity for us to check the embryos and compare the morphokinetic patterns. And what we have seen, at least for the moment, and thanks to the available data, is that we may have a prolonged pronuclear states when compared to the embryos produced from ejaculated spermatozoa. We may get to have more direct unequal cleavage, which is a bad marker for the implantation potential of the spermatozoa, of the embryo. And we tend to have lower and slower or no compaction. Another question. Will my spermatozoa carry a higher risk for chromosomal abnormalities? We know today that karyotypic assessment should be an integral part of the azoospermic male investigation, because we know that the frequency of karyotypic abnormalities for this group of males is higher. And the most commonly found chromosomal abnormality for these males is the Klinefelter, while other forms, whether it's a syndrome or mosaicism as mosaic. Other forms of karyotypic abnormalities may also be present, such as sex chromosome abnormalities, inversions, translocation, mosaicism. And we know that when we have a chromosomal, or we should know, when we have a chromosomal abnormality, the chances for sperm retrieval are lower, and obviously we do need to have a PGD program optimized in order to provide these patients with the option of screening the chromosomal of testing the embryos before transferring them, in order to make sure that only healthy embryos with healthy set of chromosomes are transferred. But apart from the chromosomal abnormalities in the form of karyotypic abnormalities, it has been for years, we were convinced for years that these spermatozoa, because they are the product of a severely impaired spermatogenesis, have higher chances, higher risk for chromosomal aneuploidies. And our tool to test this theory was the use of FIS. But there are two limitations for this. One is that fish only test a small number of chromosomes. And the other very important limitation is that normally the availability just for testing of spermatozoa is very, very limited, because nobody wants to spend precious spermatozoa just for the sake of checking. But whatever the case, for many years, we had some publications and that data that would, with the use of fish and with the use of the limited material they had from the azoospermic and non-azoospermic men, they would provide us with data which show a clear risk of chromosomal aneuploidies in these spermatozoa. This theory, however, was recently challenged with the use of a modern genetic tool, which is well known, the NGS, obviously, and which showed that maybe this conclusion does not represent all our non-obstructive azoospermic men, and it mostly represents the limitation of the fish methods. So on this level, we expect the new genetic tools to take over and clarify this. So there is no consensus on this regard. However, there is consensus for the subgroup of non-obstructive azoospermia that have been gone through chemotherapy. These group of populations have been proven to carry, due to the chemotherapy, a higher risk of sperm aneuploidy. And for this group of patients, it would be recommended and advisable to consider PGD when they proceed to ICSI. What are my chances for a clinical pregnancy? As I said earlier, the chances overall for positive sperm retrieval and fertilization and pregnancy are lower. Thanks to these newly deep learning machines, where we want to create algorithms and powerful predictive tools, it was shown in a recent study that parameters and biomarkers such as the clinical type of azoospermia, increased testicular size, increased FSH and LH and testosterone favors prognosis, while increased lower age, higher antral follicle count, and higher AMH also favors a positive outcome. Will the embryos produced be able to support full-term pregnancy? Yes, the data we have from all these years since 1993, where we have thousands of cycles have been performed using spermatozoa from non-obstructive azoospermic men. It has been shown, clearly shown, that first we have an increasing use of testicular spermatozoa, an increasing use of surgically retrieved spermatozoa, and the outcome seems to be reassuring, both in terms of perinatal outcomes and neonatal outcomes. And the last and very important question that I hear often is, what about a negative biopsy? Can we use spermatids as a good alternative? I've been working with spermatids back in 1997, and I spent lots and lots of working hours trying to find and identify spermatids. What we do know today, after 24 years of working or more, is that these methods of spermatid injection instead of mature spermatozoa remains highly inefficient. We need a big number of oocytes to have very few number of embryos. It is technically challenging because it's a challenge in the raw sample to identify spermatids, and spermatids have an issue of very low, we have the challenge of oocyte activations. This embryo has to be exposed in oocyte activating chemical factors. There are lots of safety concerns, such as DNA methylation of these spermatids, genomic imprinting issues, and immature paternal centrosome. So, with all these challenges remaining all over the years, ASRM have declared this approach as experimental and not recommended for clinical practice. I will move on now and try to present to you the key factors for a successful program from non-obstructive azoospermic patient. I'm going to talk about more practical aspects. So, in order to maximize the chances for this patient population and their prognosis, we need a multidisciplinary approach. We don't, and gynecologists with an embryologist are not enough. We do need other specialties as well, such as molecular biologists, geneticists, genetic counselor, andrologists, urologists, and endocrinologists. And all of them have to combine a good experience in investigation of non-obstructive azoospermia with good knowledge of preoperative optimization practices, optimized testicular biopsy procedures with good experience and equipment for microtessor, optimized clinical protocols for ovarian stimulation and embryo transfer, experienced and up-to-date genetic department, and genetic counseling, since the chromosomal and genetic factors are important here. And a critical key factor for the treatment and care of non-obstructive azoospermic males is the laboratory, and how optimized the procedures run in this lab are. So, critical procedures for non-obstructive azoospermic men is testicular tissue processing, testicular tissue selection, cultural and laboratory conditions, and the PGD program. Testicular tissue processing in non-obstructive azoospermia is critical because it will contribute in the positive sperm retrieval outcome. A good processing procedure will maximize the chances of identifying the spermatozoa in the sample. But caution, and really, which is we will need while processing the sample to make sure that all the steps taken during the process needs to be gentle in order not to harm the ability of spermatozoa to fertilize and support embryonic development. That's why the recommended steps are to rinse, first of all, gently the tissue piece received from the surgery in order to rinse away off the red blood cells. And then to proceed with the processing, which in most of the cases is mechanical. So with the mechanical dissection, which may be tissue shredding, squeezing, or we may use even a strainer or grinder, whatever we are more familiar with. We really tend with a mild way to homogenize our tissue pieces in order to make sure that they are thoroughly processed in a gentle way, in a stable room temperature, in order to maximize and make sure that all the spermatozoa that may be present in our tissue piece will be released in our medium. And the next step is to take this homogenized sample under the inverted microscope and scan it in order to check for the presence of spermatozoa. And depending on the concentration found, we may load our sample on a gradient. If we have high presence of spermatozoa, we may choose just to wash it and take the pellet. In case of low presence of spermatozoa, and in this step we may consider cryopreservation. But if we are to continue with ICSI because it's a fresh biopsy approach, then in case of rare spermatozoa, we may even not avoid even the washing procedure. We may just load our sample on ICSI dishes, in few quantities, in order to disperse and have a clear image of all the cells. Optionally, and depending on the case, we may also use collagenase treatment in order to remove whatever tissue pieces remain, especially when we cannot see spermatozoa. And by collagenase treatment, we may make sure that there are no tissue pieces, so whatever spermatozoa are present will be seen and identified. Or we may use erythrocyte lysis buffer in case, despite the rinsing, we still have lots of red blood cells, which will create a barrier and prevent us from clearly searching the spermatozoa. But while this is a good approach, it has been recently published in 2020 that the use of erythrocyte lysis buffer may deteriorate DNA fragmentation. In this regard, I would recommend to resort to erythrocyte lysis buffer, keep it as a last option, and better focus on how to advise the operator, the surgeon, to avoid excess bleeding and try to give us tissue pieces with free or with as few blood as possible. And it's good for us to really spend some time gently rinsing or moving our tissue piece from one washing buffer to the other in order to get rid of the excess red blood cells, rather than putting our testicular tissue samples and spermatozoa through the erythrocyte lysin buffer. One of the most important steps when processing testicular tissue piece, testicular spermatozoa, is the sperm selection. It may take hours, but it's critical because it's a step where you can optimize paternal factor and increase the chances for the couple to have embryos, good blastocysts, and a better prognosis for a positive pregnancy outcome. We know that in these tissue pieces and in these samples, having a motility in our spermatozoa, it's not that often, and it's not that expected. In an effort to identify the viable immotile spermatozoa versus the non-viable spermatozoa, in case there is no motility in our sample, even after some time of incubation, which works in order, and it may increase, it may stimulate the motility of our spermatozoa. Over the years, the use of motility stimulators has been developed, with pentoxifylline being our first choice normally. Over the recent years, we have started using theophylline or other kind of sperm stimulators, which all of them still seems to work well, because after the exposure, after the addition of these chemical factors, we can see within a few minutes our spermatozoa responding, and with twitching or even moving, they can start twitching or moving. So in this way, we can verify that our spermatozoa are viable. So it remains to select the ones that are moving or twitching and have a better morphology. In case we don't have this kind of response after the exposure of the chemical reagent, then we may try the host test, the hyposmotic sperm test, which seems to work well for these cases, where we place in a dilution of our medium with water And it seems that the immotile but viable spermatozoa, they respond to this host test by curling the tail. And it has been proven and shown that when we use a host-reacted spermatozoa, we get to have acceptable fertilization outcomes and good embryo development and chances for a pregnancy. We can also use the sperm tail flexibility test, where we touch the tail and try to identify the ones that are not rigid, and it's a sign of viability. Or we can even shoot with our laser system, and the ones that react to the laser test shots, the laser shot test, are good to use. What about morphology? Because normally in these samples, apart from the very low percentage of motility, we may have very low percentage of presence of typical forms of spermatozoa. And while IMSI can be considered, please be aware that IMSI, according to a recent Cochrane study, has not proven its benefit. At the moment, the evidence of which favors the use of IMSI is low. But apart from that, normally, especially non-obstructive azoospermia, it's not that often that we have the luxury of selecting spermatozoa based on their morphology. So what I would recommend for you is that I would go for just identifying first the ones that are motile, keep them separately, even if I had to use host test or pentoxifilin or even the laser if it's available in your setting. And once I have the group of usable spermatozoa, then these spermatozoa are more than the oocyte I need to fertilize, then I would go and make a short list or create a new group of spermatozoa that have better, the most favorable morphology. And this is the best you can do, at least for the moment. Cryopreservation, as I said before, it's of critical importance. So far, it seems that most of us are using the approach that has been developed for the ejaculate spermatozoa, which, while it's what we have used to do so many years, it may not be so appropriate for the spermatozoa for this group of population. I think we have reached the time when we should question the efficiency of this approach. Slow freezing approach means that we have to load our sample, or testicular sample, after the processing or even before in vials or in straws, and use the vapor approach or the gradient, the programmable freezer, in order to freeze store our samples. Programmable freezer is the one we are using because I think and I feel that the vapor phase creates a variation in the execution steps. So you cannot be sure what is the level of temperature dropping you are achieving with the use of vapor, while with the programmable freezer, you have a standardized way of cryopreserving all your samples. So there have been attempts since many years, because lots of scientists in the field have identified the shortcomings of our slow and gradual freezing of our testicular spermatozoa. So other approaches have been attempted based on the vitrification method, where, according to the experience we have so far, it seems that it creates lower cryo damage, it's ultra fast, it seems to be more practical, lower costs, it allows us to freeze smaller numbers of spermatozoa, And obviously, we have already, there is an availability in the market of different carrier systems. So over the last years, we have seen an increased use of vitrification. And according to this approach, it seems that we have more higher recovery rates after thaw. Other pillars that contribute to a successful program for non-obstructive azoospermic patients are optimized culture conditions. What is the value of optimizing the processing, the cryopreservation, the selection, when you don't have an optimized laboratory condition environment? You need the best for the end point is to have a pregnancy. So you need to select, improve your selection for this patient population, but make sure that you have the best possible culture conditions for your embryos. Time-lapse technology is a good supporting technology because it will allow you to deselect embryos that have the low prognosis, exhibit low prognosis behavioral, morphokinetic behavior, such as reverse cleavage, multinucleation, or they don't have, or the timing of compaction is very much delayed. And PGD program is also important and critical because, as I said before, chromosomal abnormalities are quite often in this patient population. So PGD program may need to be added in our treatment plan. And all what I have said, if it's not within the context of a thorough quality control program and assurance, it loses its meaning, because it's absolutely of importance to make sure that we measure all our procedures and we make sure that we have a good level of performance at all steps. We need to add to our non-obstructive azoospermic males, to our program for non-obstructive azoospermic males, all the relevant KPIs that will need to be followed to make sure that we have a clear and methodology for data collection. We have set the frequency of data monitoring. There is an assigned monitoring team. We have set what are the competency and benchmark values in order to, we have validated the technique of data collection in order to make sure that what we are measuring reflects the reality. And once we have our data and we are confident with them, obviously publishing our data is very important, at least for this period. So KPIs that we can use for assessing our non-obstructive azoospermic, for our program for non-obstructive azoospermic males are sperm survival rate per etiology, fertilization rate for fresh, frozen, or for per etiology, blastocyst rate for fresh or frozen spermatozoa and per etiology, implantation rate, again for fresh, frozen, and etiology, and delivery rate. So with all this data, we can monitor the efficiency of program, and once we have the data, we can make sure that we are operating within acceptable levels, and we can improve the performance and follow it through the years. And this way, we can have all the data and turn our data into valuable information, and this information into valuable knowledge that we can share with our patients and with the scientific community. And while we are thrilled and happy that thanks to the progress of science, and only the progress of science, these men, from being untreatable, they have now hope, and they can, for the first time in the history of humankind, can hope to have their own genetic offspring since 1993. we can acknowledge that nowadays, in 2021, there are still lots of challenges ahead. First of all, at diagnostic level, very high portion of these non-obstructive azoospermic men are termed idiopathic, which means that we don't know where the cause of their azoospermia is lying. At therapeutic level, we have low efficiency with our medical treatments and approaches, or with the interventions such as varicocele repair. And above all, our ability to predict the presence or absence of spermatozoa in non-obstructive males is very, very low. Treatment options. Obviously, since we cannot restore the fertility of a non-obstructive azoospermic man, our treatment options lies on biopsy, ICSI, or alternative options in case of a negative outcome. But once we have ICSI, we still don't know enough about the functionality of the spermatozoa. We cannot guarantee and ensure these patients that once spermatozoa are found, they will eventually have their own genetic offspring. And last but not least at all, by giving the opportunity to this male to reproduce for the first time in the human history, what do we convey in the next generation? What does that mean for the next generation? The health, the fertility, and everything. And this is where the exciting part of science comes. Because nowadays, we have in our hands amazing genetic tools that for the first time promise us or open or pave the way for improvements in terms of diagnosis and treatment of azoospermia. And this is where a project that I'm very proud of runs in Greece, and in collaboration of our laboratory with the University of Thessaly, where our mission is to unravel the genetic base of male infertility in the Greek population. We have already some publications where specific genetic markers have been identified. And this is my project or my hobby for my free time, where I work on non-obstructive azoospermic men. They enter the program as patients. We inform them about the program, and if they consent to participate in the program, we take some genetic material in form of testicular tissue and blood, and we complete a questionnaire, and then the next step is RNA extraction, RNA sequencing, and then we assess the differential gene expression. And today, based on our first data, we have already identified more than 1,200 different upregulated protein coding genes that are overexpressed in azoospermic men, with 5 of them having high p-values, such as the protamine 1 and 2 transition protein, and the next 2, all of them involved in spermatogenesis. And we have more than 400 proteins coding genes that are underexpressed in azoospermic men. And what is fascinating here is that these genes are not related directly to the spermatogenesis, but they are mostly related to the immune system of men, which connects them, spermatogenesis, with the immune system. And our attempt is to move from the genome to genes. And to conclude, I would like you to remember that new genetic tools create a unique momentum from non-obstructive azoospermic males, because they will improve our understanding in the genetic basis of male infertility and non-obstructive men in particular. They will unravel the genetic basis of non-obstructive males. We hope that we will soon improve our knowledge and understanding in spermatogenesis and the pathophysiology of spermatogenesis for non-obstructive azoospermic men. We will be able to improve our prediction efficiency and advance diagnostic efficiency in non-obstructive azoospermic men. Omics and artificial intelligence technologies promises us new powerful tools in order, and eventually we will be able to further improve patient management strategies and care. We will soon open new eras for the development of more effective therapeutic options, hoping to be able to restore fertility for non-obstructive azoospermic men, at least for some types of non-obstructive azoospermic males. Use of advanced technology combined with artificial intelligence will eventually help us to optimize sperm selection and overall improve our success rates for non-obstructive males. And this is my motto, that each spermatozoa is equally important as the oocyte it fertilizes. And this is my take-home message from me, from Greece to you in India. Thank you.
Starting from each sperm matters, and if you can't measure it, you can't manage it. And application of omics, genetics, and artificial intelligence, along with proper selection, whom to undergo TISA, micro TISA, you have covered each and every possible question anyone could ask about this vast topic. And what a wonderful way of presenting! I was just like, I couldn't leave my screen for a minute. It was fascinating, very, very, such an excellent talk, Alexia. I loved each and every slide of yours,
You're
the
so
way you
kind.
presented, and I think so did our audience. That is being reflected in terms of these questions. I've got more than 20 questions for you, and
You
that
have
is, I
10 questions. That's incredible, amazing.
so it shows how involved they were. So I'll start with Onifade Demi Lola. She is from Lagos. Apart from testicular aspiration methods which produce spermatids, is there a way of aspirating mature sperm from the testis?
Yes, we can follow the FNA approach. We have a technique which is called testicular mapping, which involves multiply punctures of the testis in an attempt to aspirate rather than extract spermatozoa. And this can be done in a simpler setting. You don't need an operation theater for that, but you do need a very experienced urologist who would do this kind of mapping, because this kind of mapping may create a huge discomfort for the patient and bleeding. So in order not to hamper the chances of a positive sperm retrieval, I would recommend, if the colleague from African Lagos does not have an access to a well-experienced urologist, I would recommend her to consider interventions such as microTESE or at least TESE. TESE in the means of multiply testicular piece tissue rather than one blind. We go next to the we in our setting, we go next to the surgeon in the operation theater. So the surgeon takes a small piece of the testicle and we check it under the microscope. It's not a microTESE, because he just removes pieces without the use of microscope, and we are the ones that check the tissue pieces after a quick dissection for the presence of spermatozoa. And if we don't see spermatozoa, we advise the surgeon to move on to another location of the testicle, or to move to another to the other testicle. This works well for us. So for the colleagues that do not have this kind of technology at home, they don't have an access to complicated and very expensive microscopes for performing microTese, they could resort to multiply testicular sperm extraction under the guidance of an embryologist who checks under the microscope for the presence or absence of spermatozoa. FNA is quite challenging, more simple, finding aspiration, but it can create trauma, hematomas, and it may have a negative impact on sperm retrieval in a future intervention.
So I think you have just covered everything in that question. My next question is from Namrata E. Bangalore. What is the maximum FSH value for which we have chances to get sperms and TSA?
There is not a maximum that would prevent us from trying. Please remember that when we have these men in front of us, all our words are of critical importance. The one thing that he needs to know is that we will fight for him and his fertility without setting limits. So today, there is not a value of FSH that would prevent us to consider biopsy. Even of a value of 80 can be positive. We can have spermatozoa. So don't think of FSH when deciding biopsy. Unless you have very low FSH, which is a sign in combination with LH of hypogonadotrophic hypogonadism. If this is excluded, because this is another case, and our issue is that we have impaired spermatogenesis and FSH higher than expected, then exclude it from your criteria when deciding whether to proceed to biopsy or not. As long as this man has testicles that can be operated, you proceed.
Oh, that was a real information even I wasn't aware of. We were using FSH as a criteria to decide whether to go for biopsy or not. And I'll take care in future, as you said, that we'll fight till end for that spermatozoa from that person. Thank you, Alexia, for this information. Now, Jayesh from Karnataka. FSH treatment and azoospermia success rates for chemotherapy related patients to treat for azo.
As I told you, for the cancer patients, non-obstructive azoospermia is a common side effect. They have the same retrieval rate as non-cancer non-obstructive azoospermia males. Today, preoperative treatment and medical treatment with FSH or DHGNRH analogs or tamoxifen have proven to be good options, but not at a level that is statistically significant. So the evidence level is still low. I would never say no if this is recommended from a urologist or endocrinologist, because for this man, it's maybe his only way and only hope for sperm retrieval. And what I say, I don't know whether you agree, is that the best operation and the best chances are with the first intervention.
Yes.
Because if you have a second one, that means that you have to deal with the trauma from the first one. So if you have your own first operation, try to make everything, even if it's unnecessary or proved to be not beneficiary, but at least you have been trying. What is good for you to know is that while they have been reported, lots of groups have been reporting positive outcomes, there is not one of reporting negative outcomes. So if you decide to go, if there are indications, of course, to proceed with GnRH analogs or tamoxifen or whatever, or aromatase inhibitors, you do it even if you take Zero benefit. You take a risk. It's good for the patient.
Yes. Next question is from Sumit Gujarat. Recently, we have come across a study. Spermatogenesis improved by suppressing the high level of endogenous gonadotropins and idiopathic non-obstructive azoospermia. Can you put your focus on this?
I would say that I don't know about it, but I would say that since this is a very dynamic field, whatever data you have, please share them. Please. If you have this kind of information and you have good evidence that it works for the non-obstructive azoospermic man, don't hesitate, because if you go through the publication, you can see studies with 70 people, 50 patients, or even 15 patients. So whatever is important, you please publish it. For the moment, I have no experience on that because I'm the embryologist, so I'm not the one that prescribes or suggests this kind of intervention. But whoever has this kind of data in their hands and they feel confident that they do contribute for increasing the chances for sperm retrieval, it is highly advisable to share it with the community. We need this data.
Okay. So, Clinton from Africa, varicocele related azoospermia and its management.
Sorry, can you please repeat? Varicocele.
Varicocele related azoospermia and its management.
So varicocele has from all the studies and my experience, normally it's related to a positive outcome, which means that if there is a palpable varicocele, that may have an impact on the size of the testicles, it's a good advice to remove it. What we do in our setting is that if we have this kind of decision from the urologist to proceed to varicocele repair, then we try to combine it with a biopsy on the day of varicocele repair. So at the same time, we take a piece,
yes,
we freeze it in case of a positive sperm retrieval, and then we allow time for recovery. And once this is completed, we may the patient may follow a regime for with vitamins or FSH or GnRH analogs, whatever, HCG, whatever, and then we check for the sperm. 1 or 2 ejaculates, make sure maybe sometimes we may have some spermatozoa, and depending on the outcome, we may proceed to ovulation induction and fertilization with the ejaculated spermatozoa if they are present, or the frozen testicular tissue from before.
So that really makes sense and a smarter approach, I must say.
Yes.
And our next question is from Abraham, Pakistan. Differential treatment of non-obstructive and obstructive azoospermia. Differential treatment. So he wants to, I think, know how is it different, the treatment of obstructive versus non-obstructive azoospermia.
Yes, thank you for this question, and thank you for being with us from Pakistan, Africa, and all over.
Yes, there are people from Canada and so many other countries as well, Alexia.
Really, Babu, I'm overwhelmed. So obstructive azoospermia is the happy news of the day. In case we are able to verify obstructive azoospermia, because sometimes there are no data, we don't have any kind of mutation in the cystic fibrosis gene, so we never know until the day of the biopsy, where we can see that we have a normal spermatogenesis. So when we have a confirmation of obstructive azoospermia, because the man is a carrier of a mutation in cystic fibrosis, then we don't follow any kind of regime or any kind of preoperative management for preconceptional optimization. We just schedule the biopsy, and we prefer to do it in frozen because it seems that there is no benefit in going with the fresh spermatozoa. The efficiency is the same. So we schedule the biopsy. We do conventional tese instead of microtese, and then we freeze the samples, and whenever the couple is ready, we proceed to ovulation induction. But if we have questions and we wonder whether it is or not non-obstructive azoospermia instead of obstructive, then we will collaborate with the urologist and endocrinologist, explore pre-treatment options, pre-operation options for optimization. They will check all the axes. And if there are lifestyle adjustments that needs to be done, like smoking cessation, weight loss, everything, I'm very fond of these approaches. I think that optimizing the fitness of the body will optimize the fitness of the testicles and hence the spermatogenesis. And if we have to do that, it is much better to do it before the treatment and the IVF procedure. So we, in collaboration with the different disciplines, we decide a pre-treatment plan for optimization of sperm recovery before scheduling the testicular biopsy. And if the testicles are very small and we have very high FSAs and all the signs are in favor of non-finding spermatozoa, then we try to schedule a fresh biopsy instead of frozen. I know that it's complicated. I know that sometimes it's too much for the couple to handle because they both have to undergo simultaneously treatments. The woman ovarian stimulation and the man will be lost in his anxiety with what if there are no spermatozoa, what will that mean for my life? And sometimes it's too much for the couple to handle at the same time, but we try to consult them and tell them if the chances for sperm retrieval are very low, they better use the fresh approach because it may be their only chance for having a good outcome based on our own data.
Okay, great. So, Paul from Canada is asking some recent diagnosis methods which are forthcoming or newly invented. I think NOS he is asking about.
What I'm working with for the moment, and I feel very excited about this, is the genetic basis. And we've seen that the pattern of the spectrum of non-obstructive azoospermia is wide. It's a common phenotype with lots and lots of causes. Most of them lies on different genes. So there is a highly complex interaction among different molecular pathways that are controlled by more than 2,000 genes, and even small changes in one of these genes may have a profound impact on the spermatogenesis. So my aim is through the RNA expression to identify which genes are involved, which pathways are impacted, in order to pave the way to clarify the genetic basis or contribute to clarification of genetic basis. And the aim is to work together with other countries and other labs, because our genetic pool in Greece may be different from the genetic pool in India, may be different from the genetic pool in Pakistan or Iran or Canada. So by working together, we can combine our efforts and knowledge and unravel the genetic base of non-obstructive azoospermia, and hence pave the way for new therapeutic treatments, new treatment options, and optimize the options, the treatment, diagnostic, and therapeutic options for non-obstructive azoospermia, hopefully in the near future.
Very rightly said, as you have also told in your conclusion, that our aim is not to procreate a progeny, but to give a healthy child with a future health and fertility intact. Yeah. So our next question is from Jang Kong Lee from Korea. Please share any of your toughest cases tackled efficiently.
Cases
Any
that
that you tackle efficiently. Some tough case of
case
NOS.
case reports and case studies.
Yes,
I
report.
remember.
Yes. He
Yes.
wants to know
He
what was
has
the
very
toughest case.
it's amazing. This is very good because sharing experience is always good. My
Alexia,
main
you seem to like make a record, darling. More than 20 countries, I think, I have logged in today for your talk. I'm getting all the questions from international audience only.
overwhelmed. This I have nothing more to say. I'm really, really overwhelmed. So
That
I
is
remember
the power of knowledge.
I remember a case where we had a very rare presence of spermatozoa. After 5 hours, I found three spermatozoa. I was really, really, uh, well, you need to be, I really tried to make sure that I had placed all my efforts. And next day I had three embryos fertilized, three spermatozoa, 5 hours, three embryos, twin pregnancy,
Great.
which means that how you must not consider the time. As long as you have time, it's worth fighting for these men.
True. Similar thing happened with me also, Alexia, 5 years back. This guy is come with a report of Azoospermia. And when we saw his sample after doing centrifugation and everything, we were getting one or two sperms. And his wife was PCOS. So we said, okay, let's try. And he wasn't ready for TZ or anything. So we did, and we got four embryos, and we put two blast or 2 day 3 I put, and she got twins, one male, one female. So I still feel like, yeah, if we had not, like, it was hardly mobile even those sperms were, but yeah, it
But
was something
don't you feel that the age factor of the female partner is fundamental?
very important. Female takes care of all the faults of males.
As always.
Each walk of life. So, our next question is from Chris from West Indies. Can you out some light on pregnancy with frozen thaw and fresh testicular biopsy after motile and immotile sperm microinjection using the mechanical touch technique to assess viability?
Mechanical technique. We don't use mechanical technique for, we do the host test and the touch tail, he means. This is a group in the poor motility. This is the low motility, and I have shown in my presentation. Let me tell you about it. It seems that it's comparable, the pregnancy outcomes, the clinical outcomes, and the only difference is on the number of day 3 good quality embryos. We tend to have lower good quality embryos in the poor samples they have very or no low motility or very low presence or very low morphology. So the impact we have seen, it relates only to the good quality of the embryos rather to the other clinical outcomes like the pregnancy rate and the ongoing pregnancy rate is as long as you have embryos. And this is what is good. Despite the difficulty and the degree of the difficulty of the testicular tissue, while you have the embryos perform equally good. This
Yes.
is amazing to think. Even if you have one spermatozoa and it creates an embryo, this embryo is equally competent to create a pregnancy.
Yes. So our next question is from Lakshmi Shankar Narayanan from Bicholim. When we go for testicular biopsy and it yields no spermatozoa, what next? Chances of autoimmunity have already risen.
Well, I'm not in favor of spermatid injection because I've been doing that for many, many years. I have publications from back in 1997. I have spent lots of hours looking for spermatids, but I think we should not get at the moment involved with spermatid injection. Let's say and let's accept that if there are no mature forms of spermatozoa, this is the end of the route for these men. Spend as many time as you wish and can in searching for mature forms, but please don't. I would not use spermatids, immature forms, because in my experience we had less than 15% of fertilization, and we had 2 cases of abnormalities. One it was with hydrocephalus after a pregnancy, and one was with spinal bifida. We had reported this, and there were other reports similar from other experience back in 1997, and we stopped providing this option for our couples. So if no mature spermatozoa are present, then either you proceed with spermatids, but please take a consent form for the couple, because they entering unknown and very inefficient pathways, or you give them, provide them with options such as sperm donation or oocyte cryopreservation in case of fresh tester, so they will have the option at a later date to consider and reconsider sperm donation if they are not ready for the day of egg retrieval to decide.
Okay. So Saima Firdaus Khan from Akola is saying very informative and excellent lecture. And her question is spermatogenesis process may get disturbed or damaged after TISA or TISA?
It creates a trauma. We should consider that. It depends on the operator, of course, but for this tissue, after tissue retrieval, and especially if it's aggressive in terms of puncturing different sides of the testicles, you may have lower activity afterwards. You may have lower volume or the quantity of Leydig cells. You may have testosterone insufficiency afterwards. So it is very critical who's going to operate the testicle, how mild the approach, the surgical intervention approach will be. So that's why I'm telling that it's multidisciplinary approach, and everybody needs to have a good knowledge and experience of what they're doing.
Yes. So this is very interesting question, Alexia. Even I wanted to know what is the management of epididymal cyst? Any option besides cyst excision or obstruction plus or drainage?
I don't know about that. I'm
Yes.
sorry, because this is more urological.
Urological question, yeah.
It doesn't reach my practices that often. What I know is only the azoospermia and how to retrieve spermatozoa, and it's upon to the urologist to decide whether he will puncture the epididymis or he will go straight to the testicles. I just follow the route, but in case somebody works with epididymal spermatozoa, please know that there is a publication where it says that fresh epididymal spermatozoa perform better than frozen epididymal spermatozoa. So if epididymal spermatozoa is the option, you better go with the first. But cyst, I don't know, sorry.
So with this, we finish our question answer session. What a like wonderful session we had with interactions, and in spite of you covering each and everything, there were so many questions from audiences, and you did like try to solve each of their queries. Thank you so much, dear Alexia. Till we meet in person, take
Yeah,
very good care. Yeah, and let's meet soon. Thank
hopefully,
you.
hopefully we will meet soon. Hopefully in person. Thank you for
Yeah.
the invitation and the great honor audience from all over the world and the excellent questions.
Thank you,
Have
audience, for
my
giving
data,
your
please,
feedback.
sir. I'm at the disposal of everybody in case they have more questions.
Yes. So thank you so much,
Thank
each
you.
and one of you.
Thank you.
And let's meet next week again. Bye bye till then.